begin our second session for the PBS. Let's begin our session with Umul Kitab Al-Fatiha. Okay, so let's continue with the next presenter.
Assalamualaikum, can you hear me?
Yes.
Hello. Okay, so my name is Nuranis Bentri. Assalamualaikum, my name is Nuranis Bentri Duan, and my topic for today is neonatal anemia. So this is basically my outline for today. We start off with the definitions, and then the pathophysiology, and lastly the diagnostic approach, which comprises of the history, physical examination, investigation, and management. But first and foremost, I'm sorry because I switched off the camera due to poor internet connection. Very sorry. And so next. So first, we go to the definition first. Anemia can be defined as hematocrit or hemoglobin concentration more than 2 standard deviation below mean for postnatal age. And according to Nelson textbook of pediatric, anemia can also be defined as a hemoglobin value less than the normal range for hemoglobin for birth weight and postnatal age. So next. So this is basically a picture showing the globin productions in prenatally and postnatally. So the fetal erythropoiesis occurs sequentially during embryonic development in 3 different sites, which is the yolk sac, liver, and the bone marrow. For the yolk sac formation of red blood cells, it begins since the 20th day of gestation. And in the mid-gestation, the erythropoiesis mainly occur from the liver and the spleen. And since last trimester, the bone marrow is the major erythropoietic organs. And at birth, almost all the red blood cells are produced in the bone marrow. And as you can see in the picture at the right side, so normally in adult hemoglobin, we have 2 alpha chain and 2 beta chain. But in fetal hemoglobin, it comprises of the 2 alpha chain and 2 gamma chain. And HbF, the main hemoglobin during fetal life, immediately before terms, they begin to synthesize the beta hemoglobin chain, and there will be a reduction in the gamma chain after birth. So gradually, the fetal hemoglobin will be replaced by the adult of hemoglobins. So next. So this is just a table showing the normal value for hemoglobin in full-term and premature infants. So we'll start off with the term infant first, which is the second columns. So at birth, the normal hemoglobin level would be 19.3. And then as you go to 0.51, you can see that there is a decreasing trend of the hemoglobin. And by 9 to 12 weeks, the hemoglobin level will be at its lowest. And it is called nadir point, where the hemoglobin will be 11.2. And then after the nadir point, up to 6 months, you can see that there is increasing trend of the hemoglobin levels. And the same pattern happened in premature infant, but the value is lower than the full-term infants. So at birth, the hemoglobin value would be less than the full terms, and it will be 9.4 at the nadir point. And as you can see, at the nadir point, the hemoglobin level is lower, and the nadir point occur earlier than the full-term infant. So after the nadir points, the hemoglobin start to rise up again. So this is important when we come to discuss about the physiological anemia later. So next. So next. So next we discuss about the pathophysiology. So in the pathophysiology, we'll be talking about 4 things that could cause anemia in neonate, which is physiological, hemorrhagic, which is loss of red blood cells, hemolysis, which is the destruction of the red blood cells, and hypoplastic, which is decrease in red blood cell productions. So next. So first we talk about the physiological anemia first. So this is normal, and it is the most common cause of anemia in young infants. And so what happened in physiological anemia is that at birth, during respiration, the oxygen become more available for binding to hemoglobins. And also the normal developmental switch from fetal to adult hemoglobin synthesis actively replace the high oxygen affinity fetal hemoglobin with low oxygen affinity adult hemoglobin, which can deliver a greater fraction of hemoglobin bound oxygen to the tissue. So therefore, immediately after birth, the increase in blood oxygen content and tissue oxygen delivery downregulate the erythropoietic productions so that the erythropoiesis is suppressed. And the hemoglobin concentration continue to decrease until the tissue oxygen needs are greater than the oxygen delivery. So normally, this point is reached at the nadir point that I explained earlier. So as hypoxia is detected by the renal or hepatic oxygen sensor, Erythropoietin production increase, and the erythropoiesis resumes, and the hemoglobin level rise up again. So as it is physiological, it usually do not require any extensive evaluations or treatments. So how do we differentiate physiological anemia from pathological anemia? Is that in pathological anemia usually occur within the first month of life, and the hemoglobin level in pathological anemia will be lower than typically seen with physiological anemia, that the value that I just showed earlier. And in pathological anemia, usually we can see the pathological sign itself. For example, in hemolysis, we can see jaundice, scleroticus, dark green, and symptom of anemia. So next. So this is just tables that show some of the causes of neonatal anemia based on its pathophysiology. So I will explain some of it later. So next. So first we go on to the hemorrhagic anemia, which is our loss of the red blood cells. So in hemorrhagic, in units, the absolute blood volume is low, which is in preterm is about 90 to 105 ml per kilogram, and in term is about 78 to 86 ml per kilograms. So in this case, any blood loss as little as 15 to 20 mils of blood may result in anemia. And to be noted that in an infant with chronic blood loss can compensate physiologically and is typically more clinically stable than an infant with acute blood loss. So those in the circle those in the circle can be the causes of hemorrhagic anemia that I explain later, which is antepartum blood loss, intrapartum, and also the postpartum blood loss. So next, we move on to antepartum blood loss first, which is first is the fetal-maternal hemorrhage, which is bleeding from fetal into the maternal circulation, either before or during delivery, and it can occur spontaneously or from maternal trauma, amniocentesis, external versions, or tumor from the arising from the placenta. And it can affect around 50% of pregnancy, but volume of blood loss is usually very low and not enough to cause hemorrhagic anemia, because usually the blood loss is about 2 ml and it is well compensated by the fetus.
Presenter, is there
Yes.
any way we can test whether there is presence of fetal-maternal hemorrhage?
Yes, there is a test to confirm the fetal-maternal hemorrhage, which called the Clarer-Bedke test, and it usually done at deliveries to detect significant amounts of fetal hemoglobin in the maternal blood. So next, eh, previous slide. Um, so usually it is not significant, and if there is substantial amount of blood loss, more than 30 mils, it can cause hemorrhagic anemia, hemorrhagic anemia, and it occurs in about 3 in 1,000 pregnancies. And next is the twin-to-twin transfusions. It is usually due to unequal sharing of blood supply, and it affects 13 to 30% homozygotic or monoclonic twins that share the same placenta. And if there is a significant transfer, the donor could have anemia and also heart failure, and the recipient could have polycythemia and hyperviscosity. The other causes of antepartum hemorrhagic anemia is cord malformation and placental abnormalities, which I explain later. Next. In cord malformation, we have vasa previa and filamentous insertions. So from the cord malformation, we go, in the first picture is the vasa previa, whereby the fetal vessel transfers the fetal membrane over the internal cervical os, and the pressure from the fetal head can actually cause the bleeding. And for the filamentous insertion, as you can see in the second picture, the first one is the normal, where you can see that the umbilical cord is coming out of the placenta into the fetus. The second one, you can see that the cord is actually coming out a little bit away from the placenta. So in that space, there'll be exposed vessel, and it becomes worse when it coexists with vasa previa as well, where you can see the exposed vessel run under the fetal head, and pressure from the fetal head can cause much bigger bleeding. So next is next. Next is the placental abnormality, which it can be due to placenta previa and abrasion placenta. And surely in abrasion placenta, there will be a lot of bleedings. So next, intrapartum causes of hemorrhagic anemia. So it usually happens in precipitous delivery, in which there is a rapid and spontaneous delivery which causes hemorrhage due to umbilical cord tearing. or it can also happen due to obstetric accidents such as incisions of the placenta during cesarean delivery, or any birth trauma that can happen, let's say in instrument stations. And also subgallellar bleed, which can rapidly extend into the soft tissue, sequestering sufficient blood volume to result in anemia, hypotension, shock, and death. And sutures are not fused yet, and yeah.
Yeah, continue.
Sutures are not fused yet, and there could be a large volume of blood hiding under there. And also the other causes could be obstetric trauma, which cause occult visceral or intracranial hemorrhage.
What is subgallel bleed?
Subgallel bleed, as you explained in the previous in last week, is bleeding, subperiosteal bleeding.
No.
Subperiosteal pula.
Subperiosteal is the cephalohematoma.
Cephalohematoma. Subgallel is the
The aponeurosis.
Yes,
yes.
this is aponeurosis, just above the loose connective tissue.
Yeah.
Okay. And this is a huge, massive potential space. Your whole body is connected with this. So it's like pernah tengok orang lapar lembu tak? Pernah tengok? Siapa pernah tengok di lapar lembu kan there's a layer yang dia separatekan between the skin tu, yang dia buka skin tu. So that is the subgallel area. That is the aponeurosis. So this is a space that connects your whole body. So your whole skin can actually be separated with this space. Okay, fine. Proceed next.
So the previous slide. So in the other causes would be obstetric trauma, which can cause occult visceral or intracranial hemorrhage. And as you know, neonates with intracranial hemorrhage can lose sufficient blood into their intracranial vault to cause anemia, and sometimes the hemodynamic compromise, such as hypotension or shock. Because unlike in older children, we have lower head to body ratio, and in whom intracranial hemorrhage is limited in volume because the fused cranial suture do not allow the skull to expand. So instead, there will be buildup of intracranial pressure, and that may be able to stop the bleeding. And then they will start to show the sign of increased intracranial pressure. While in neonate, because the suture is not fused yet, there will be less signs of increased intracranial pressure because the intracranial space can still expand. So next. Next is the postpartum causes of hemorrhagic anemia. It is usually an enclosed hemorrhage, and it may suggest obstetric trauma or severe parental distress, such as caput succedaneum, cephalohematoma, intraventricular hemorrhage, and visceral hemorrhage. There can also be defect in hemostasis, such as in congenital coagulation factor deficiency, consumption coagulopathy, such as in disseminated intravascular coagulopathy, and sepsis. And it could also be because of vitamin K deficiency, and also thrombocytopenia, whether immune or congenitals. Lastly, it can also be caused by iatrogenic due to blood loss, due to blood draw. And we must remember that neonate has a smaller blood volume. So if we draw a lot of the blood from them, we can actually induce anemia. So next. So this is just a picture showing a type of intracranial and extracranial cause of effect of the birth trauma that Dr. has explained last week. Next. So next is the hemolytic anemia. So besides hemorrhage, so next is the hemolytic anemia. So this is besides hemorrhage, it can also be due to destructions of the red blood cells that can also be called hemolytic anemia. So next. So in hemolytic anemia, there can be divided into three causes, which is immune, non-immune, and congenital erythrocyte defect. In immune, it can be caused by ABO erythrocyte incompatibilities or autoimmune hemolysis. In non-immune, it can cause by sepsis, starch infection, or drug-induced like penicillin, quinine, and chlorpromazines. And in congenital defect, we can divide it into three, which is hemoglobinopathy, like thalassemia. The defect in the enzymes, which is like, for example, glucose 6-phosphate dehydrogenase deficiency and pyruvic kinase deficiency, and defect in the membranes of the red blood cell itself, such as hereditary spherocytosis and elliptocytosis. So next. So in hypoplastic anemia, it can be congenital or acquired. In congenital cause, we should think of Fanconi anemia and diamond black fan syndrome, which is a bone marrow failure syndrome, and it can also be congenital leukemia and sideroblastic anemia. So in acquired, we should think of infection like parvovirus or rubella, nutritional deficiency like iron, copper, folate, vitamin B12, B6, and vitamin A, C, and E. And we should also think of aplastic anemia. And lastly is caused by the anemia of prematurity, which Dr. has explained in the prematurity lecture. So, but for summary, the anemia of prematurity is the exaggerations of the physiological anemia in infancy, and the causes could be due to shorter red blood cell lifespan, impaired erythropoietin productions due to immature liver function, and repeated blood group sampling in preterm infant. So next. So next we move on to the diagnostic approach. First, the clinical presentations. In clinical presentation, we should determine the following factors, such as the age of the presentation, the associated clinical feature, hemodynamic status of the infant to assess the severity of the anemia, and also presence or absence of compensatory reticulocytosis, which could give us the clue about the possible diagnosis. So next, so this is a difference of clinical presentation in different previous slide before. Okay. So this is just different type of presentation in according to the pathophysiology. So all of these pathophysiology, three type of presentation have pallor, but in hemorrhagics, the anemia could be present at birth, usually sudden onset, and the pallor occur without jaundice, and cyanosis can also be there, which is unrelieved by oxygens. The neonate can also have a respiratory distress and decreased perfusion progressing to hypovolemic shock, and with decreased central venous pressure. And usually in lab investigation, they will have normochromic or normocytic or normochromic red blood cell indices. And we should look for any source of bleeding in this type of patients. So in hemolytics, aside from pallor, we also have jaundice, which contrary to the hemorrhagic, which doesn't have any jaundice. And jaundice in hemolytic is usually the first symptoms due to the presence of unconjugated hypobilirubinemia. And the patient could also present with anemic symptoms. And also hepatosplenomegaly, also with compensatory reticulocytosis in the lab investigations. And also the neonate can have seizure due to the bilirubin encephalopathy. So in the hypoplastic, usually uncommon cause of anemia in neonates could usually present with pallor and anemic symptoms, but with absence of jaundice and no reticulocytosis. And usually they can have enlarged spleen and liver, and also with heart and renal failure, which can usually due to sideroblastic anemia. And the patient can also have non-specific correlative symptoms or generalized rash, illness, or arthropathy, which, for example, in parvovirus B19, and also anemia of prematurity. So next.
I have one thing to remind you, hemorrhagic, in terms of hemorrhagic, one of the causes that I've seen several times is actually extravasation from IV lines. So sometimes, you know, newborn babies, they have umbilical lines, they have arterial line. So sometimes if it's not connected properly, there can be extravasation from it. There can be bleeding from the line. If it's not connected, sometimes dia ada dekat dia punya T connector, for example. Dia punya stopper tu is not put properly. So sometimes this babies, even with the usual IV cannula, they can have significant bleeding. I've seen babies bleeding, going into shock because bleeding from the arterial line. Dia tak connect properly, dia punya connection dekat arterial line dia. So massive bleeding, massive hemorrhage from the arterial line. So this is a thing that you need to remember. Okay, all right, proceed.
So we have to also include presentations of the form of the neonatal anemia. For example, in twin-to-twin transfusion, we can see growth failure in the anemic twins. And in occult internal hemorrhage, for example, intracranial, we can see bulging anterior fontanelle and neurologic signs like altered mental status, apnea, and seizure. And in visceral hemorrhage, most of the liver is damaged and leads to abdominal mass. And in pulmonary hemorrhage, in radiographic, we go for radiographic of pacifications of hemothorax with bloody trachea secretions. Next. So in history, you have to ask the clinical presentations that I explained earlier and also rule out a variety of causes of the anemia. So in the history of presenting illness, we should ask the age of the patients, onset of the symptom, whether the patient have anemic symptom or jaundice, and also the associated symptoms. In birth history, in antenatal, we can ask whether it is single or twin pregnancy, any antepartum hemorrhage, and the mother's blood type and rhesus. Intrapartum, we could ask about the type of delivery, the gestational week, any bleeding, placenta, any problems during the pregnancy like placenta previa, placenta abrasions, or any instrumental delivery or birth trauma. And in postpartum, we should ask if there is any bleeding tendency, birth trauma, have swelling, any exchange or transfusion done to the neonates. And in feeding history, we can ask about the type and amount of milk. And for growth and development, we can ask if there is any failure to thrive. To, and in family history, we can ask about the history of thalassemia, anemia, ethnicity, hereditary or hereditary blood disorder. So next, in physical examinations, we in general we have to assess whether the neonate is active or not, whether it is lethargic looking, whether there is any scalp swellings that could signify cephalohematoma, any moldings, and color we have to look for pallor, jaundice that could signify hemolytic anemia, and whether the baby is cyanosed. And we should also look for dysmorphism that could lead to differential diagnosis of congenital type of anemia, for example, like Fanconi or Blackfan's, Diamond Blackfan syndromes. And we could also look for bleeding tendencies. We should also, next, we should also look for hemodynamic status to assess the severity of the anemia itself and also the vital signs. And in respiratory, we should look for signs of respiratory distress. And in the abdomen, we should look for hepatosplenomegaly. And in skin, we should look for rash, which can signify infectious causes of anemia. And we should also look for any bruising. So next. So this is some of the investigation that could be done in neonatal anemia. So first we can do the full blood count, including the reticulocytes, to determine which type of anemia it is. And we could also do full blood films that to acquire the peripheral blood smear. And we could evaluate the morphology of the red blood cells. And also we can do blood typing and direct home test for immune hemolytic anemia. And we should also look for bilirubin, total, both total and indirect. And this is what I explained earlier, the Clarobacter test that we should check to check for fetal hemorrhage. And we can also do coagulation studies, hemoglobin electrophoresis. And if we suspect any internal bleeding, we can do ultrasounds of the cranial and also the abdomens. And bone marrow aspiration is rarely needed, but can be done. So this is just the summary of the investigation. You can go through it later. So next. So lastly, the management. In management of the neonatal anemia, prenatally, we can give ROGAM injections to rhesus negative mother as a prevention for the hemolytic anemia. And fetal transfusion is rarely required Intraperitoneally, we can perform delayed cord clamping so that we can deliver extra amounts of blood volumes to the neonates. And in postpartums, simple transfusion for symptomatic, we can do simple transfusion for symptomatic newborn. For example, in premature babies on oxygen therapy. We can also do exchange transfusion for severe hemolytic anemia. And we could also give to treat the underlying cause, for example, like iron supplements and steroid. And also we can give nutritional supplements like iron, folate, and vitamin E. And supportive therapy could also be given. For example, like we limit vaccinations in preterm infants to avoid the anemia of prematurity, and also erythropoietins. But to reduce erythropoietin is said to reduce the number of neonatal blood transfusions, but is not a routine management. So I think that's all. Any question? Thank you. Any question?
Any question to the presenter? Clear? Okay lah, fine. I don't have any issues. So I think that's quite a clear presentation. All right, proceed.
Thank you.
Hello. Okay, I will. Okay, next we will go about neonatal thrombocytopenia. Okay, my name is Siti Adawi Abidijani. Okay, next slide. Okay, for definition, neonatal thrombocytopenia is defined as platelet count less than 150,000 per microliter. And thrombocytopenia itself can be classified by its severity, where mild thrombocytopenia is platelet count 100 to 150,000. Moderate is platelet count 50 to 99,000, and severe thrombocytopenia is platelet count less than 50,000 and all is per microliter. And in severe thrombocytopenia, it is also associated with increased risk of bleeding and also result in morbidity and also mortality. So neonates that develop thrombocytopenia can be from a multitude of causes, and this can make it challenging to diagnose an underlying cause and to evaluate, and the evaluation can be extensive. But overall, thrombocytopenia occurs in a fewer than 1% of all newborns, and the highest prevalence are newborns in ICU, which is about 20 to 35% of the case, and especially in a very low birth weight preterm units. Okay, next slide. Okay. Causes of neonatal thrombocytopenia can be classified by several different methods, but in this slide, I'll divide it by its mechanism, which is increased destruction or consumption of platelet, or decreased production of platelet, or the miscellaneous causes. So in increased destruction or consumption of platelet, it can be divided into three parts, which is immune thrombocytopenia. And immune thrombocytopenia is quite important, and I will discuss about it later in the further slide. Okay, and also sequestration and trapping, like in case of hypersplenism. And hypersplenism usually due to hemolytic anemia or congenital hepatitis due to viral infection, and also Kasabach-Merritt syndrome, which is a vascular tumor. Also, in Kasabach-Merritt syndrome or phenomenon, there will be combination of giant hemangioma, thrombocytopenia, and also consumption of coagulopathy. So that's why the neonates can have thrombocytopenia. And also in platelet activation and consumption, in case of DIC, because DIC is a secondary disorder by primary underlying disease, thrombosis, and also type 2 von Willebrand disease. So in decreased production of platelet can be due to congenital thrombocytopenia, but it is a very rare condition. It is an inherited condition, but it's rare. Drug-associated marrow suppression, infiltrative bone marrow disorder, and also preeclampsia. In preeclampsia, the incidence of thrombocytopenia associated with this disorder is estimated in 1 in 100 live birth. And thrombocytopenia in preeclampsia is said due to decreased production of platelet mediated by inhibitor of platelet production. So in miscellaneous causes can be due to infection and asphyxia, because both can lead to DIC, and also dilution, because when the baby or the neonates receive exchange transfusion, they receive a blood volume that have a low platelet count. So we can see the baby to have thrombocytopenia. Next slide. So in neonates with thrombocytopenia, they can present in 3 presentation. So first, neonates diagnosed incidentally by a low platelet count when a complete blood count is obtained for other reason. For example, we take the complete blood count for sepsis workup, but we found out that the patient also have thrombocytopenia. And this patient may be asymptomatic or ill appearing due to the underlying causes. So second presentation is at-risk infant for thrombocytopenia that are detected also by complete blood count screening. And also from the history obtained from the patient or from the mother, there is presence of risk factor including maternal history of autoimmune, and also previous siblings, previous affected sibling that suggested of NNIT, and also we can identify the baby that have characteristic physical finding that include genetic and chromosomal disorder, or the baby have any congenital infection. And the third presentation is a symptomatic patient where there is evidence of bleeding, petechiae, large ecchymosis, and also oozing from the umbilical cord or puncture site. Okay, next slide. Okay, based on the clinical presentation before, so since the diagnostic evaluation could be very extensive, so it is important to obtain this relevant information. So the key factor that need to be considered are the onset of the thrombocytopenia, whether it is an early onset, which is defined as less than 72 hours of age, or late onset, which is more than 72 hours of age, or whether the baby is a preterm baby or term infant. And also from the maternal history, if the mother have any autoimmune condition, and from the family history, if there any family history of bleeding disorder or previously affected sibling during infant, that will suggest us for an AIT. And also birth history, antenatally, if the mother have preeclampsia, the baby is a intrauterine growth restriction or any congenital infection, and also perinatal asphyxia. So next slide. So from the physical examination, we should look for evidence of bleeding. If the baby is an ill-appeared or well-appeared baby, any presence of jaundice or hepatosplenomegaly to suggest congenital infection, or any associated syndromic finding like in thrombocytopenia absent radii, there will be bilateral absent radius of, and also in chromosomal abnormalities, we seek for any features of trisomy 21, 18, 13, and also Turner syndrome. Okay, next slide. Okay, physical like slide before, physical examination should pay particular attention to the skin for sign of petechiae or purpura, as well as the oral mucosa, which are the most common site for bleeding to occur, and also splenomegaly, microcephaly, and blueberry muffin rash in torch infection. In Fanconi anemia, the baby can have radial and thumb defect. In thrombocytopenia, absent radii, there will be absent radii at the upper limb. And also in case of Kasabah-Merritt syndrome, there will be a local skin lesion or hemangioma. Okay. So from the history and also physical examination, we can now prioritize which diagnosis is more appropriate for each presentation. So because when assessing the infant with thrombocytopenia, it is more useful for us to consider the overall clinical features of the patient, as the common causes of thrombocytopenia in a sick infant tend to be different from most likely causes in well-appearing infant. Okay. So in ill-appearing premature baby, the thrombocytopenia is it is commonly secondary to sepsis. So perinatal acquired infection like torch infection or group B streptococcus infection, and also birth asphyxia are also frequent is the culprit that associated with the IC that will lead to thrombocytopenia. And this parental insult typically cause thrombocytopenia within the first 72 hours of age. And it also said that, belum lagi. Okay. And it also said that baby with birth asphyxia is more common to have thrombocytopenia than baby without birth asphyxia. Although the underlying mechanism is uncertain, there are data that suggest that hypoxia contributes to decrease in platelet production. Okay, okay. So in well-appearing full-term baby, although term infant can also have thrombocytopenia from all the I have mentioned before, NAIT, which is neonatal alloimmune thrombocytopenia, is the most common cause of thrombocytopenia in a healthy full-term infant and usually resolve within a week. So this is the important point in this slide. Okay, next slide. So neonatal alloimmune thrombocytopenia or NAIT. So immune-mediated process are among the most common cause of neonatal thrombocytopenia. Autoantibody, drug-dependent antibody, or in this case is alloantibody, mediate platelet. Alloantibody will mediate platelet destruction through interaction with platelet membrane antigen. So NAIT occurs when the fetus inherit a paternal platelet antigen that is not carried by the mother, and this antigen then become a target for the maternal antibodies. So during pregnancy, the mother will form immunoglobulin G or IgG class antiplatelet antibody against this foreign antigen which cross the placenta and destroy fetal platelet that express the paternal antigen. So NAIT affect estimated about 1 in 800 to 1,000 children of live birth, and maternal platelet are not targeted and are thus within normal range. And NAIT frequently cause disease in a woman first pregnancy. So NAIT can produce most pronounced thrombocytopenia that lead to platelet can be typically below 50,000 microliter. And also 10 to 30% of newborn with NAIT can also develop intracranial hemorrhage. So all neonates with suspected NAIT should be screened for ICH with head ultrasonography because ICH can have a significant neurological sequelae. Like I mentioned, 20% of the neonates can have neurological sequelae and also 10% can have death. So next. Okay, kat mana ni? Okay, the clinical manifestation of the baby, baby is a well child, which means the baby have no underlying infection, but they have a generalized petechiae or purpura due to the thrombocytopenia or low platelet. So the diagnosis of NAIT is made by demonstrating platelet antigen incompatibility between the mother and also the neonates. So this can be done in two ways, where the first detection of maternal anti-HPA antibody in the infant circulation or HPA genotype mismatch between the infant and also the mother. So for the treatment for NAIT is we need to transfuse the baby with washed maternal platelet. So maternal platelet can only be used if they are washed because circulating antibodies will also be present. So what that mean by washed platelet is we remove the plasma because we didn't want any more antibody. So we can also use random donor platelet, but we afraid that the random donor platelet also contain the foreign antigen that the antibody will attack. And also in conjunction with the platelet transfusion, intravenous immunoglobulin or IVIG can be helpful in management of NAIT in neonates. So in next pregnancy, we need to administer, if the mother wish to be pregnant again. So prenatally, the mother need to be administered with intravenous immunoglobulin. And therapy usually begins in the second trimester and continue throughout the pregnancy because in subsequent pregnancy, they are often more severely affected than the first one. Okay, next slide. Mm. Next is neonatal autoimmune thrombocytopenia, which is a condition where there is mediated by maternal antibody that react with both maternal and also fetal platelet. Different from NNIT. NNIT it only attack the neonate's platelet, but in autoimmune it attack both mother and also baby platelet. So typically it will cause mild to moderate thrombocytopenia, and this occur if the mother have autoimmune disorder like SLE or ITP. And the diagnosis is apparent from the mother medical history and also maternal or the mother itself have maternal thrombocytopenia. Hence, family history is important to establish the diagnosis, but many women can be asymptomatic. So, mother of infant with unexplained neonatal thrombocytopenia should be investigated for the presence of autoimmune disorder, as neonatal thrombocytopenia can be the initial presenting sign. And also, healthy mother can have gestational thrombocytopenia also.
Remember this one, this autoimmune thrombocytopenia is actually maternal antibody, not baby to punya antibody. Because you know newborn babies sometimes they don't produce antibodies well yet. Their immune system is still immature. But this autoimmune is not, usually we say autoimmune is when our own antibody attacks our own cells. But this autoimmune antibody, autoimmune thrombocytopenia is basically maternal antibody lah. So this maternal antibody is the culprit, as opposed to alloimmune thrombocytopenia. So alloimmune thrombocytopenia is again maternal antibody, but it's against paternal punya antigen on the platelet. Okay, all right. Next.
Okay. And neonates with thrombocytopenia associated with maternal autoimmune disease only for the treatment it only require supportive management. But if there is thrombocytopenia or bleeding, then we need to administer intravenous immunoglobulin or platelet transfusion. Okay, next slide. This is basically the overall investigation if we suspect the baby have thrombocytopenia. So first is complete blood count and an asymptomatic infant found to have a low platelet count should have the test repeated, and also having decreased count of multiple bloodline should prompt consideration of infiltrative disorder of bone marrow like anemia or leukopenia. We can suspect for bone marrow suppression. And in general, no further diagnostic testing is needed for a patient with mild thrombocytopenia or for those with moderate thrombocytopenia due to placenta insufficiency. So they only need complete blood count. But if we suspect that the patient have other disease, we can do peripheral blood smear and peripheral blood smear for any abnormalities in platelet morphology. And also, an infant with platelet below 50,000 per microliter, or we suspect for diagnosis of an AIT, we should do head ultrasound. Next slide. And also do coagulation study in the if we suspect for the IC, blood culture for unwell neonates, platelet antigen typing in NAIT, if there is any physical abnormality, we can do genetic screening and also torture screening.
This platelet antigen typing for NAIT, I think was it 2 months back? We have a patient that we diagnosed as NAIT. The thing is, to send the test, there's only one lab in the whole Malaysia that's doing it. It's in the national Pusat Darah Negara, PDN. So in Pusat Darah Negara, there's no other, not even any private lab in Malaysia that can do this. Only in Pusat Darah Negara. So and we need to send blood from mother. I think 20 mils. We took 20 mils blood from mother, 10 bottles from mother, and then 10 mils blood from the father, and another around 10 mil as well from the baby. And then it needs to be taken and sent by appointment. You cannot just send. You need proper appointment and things. So it's very difficult, very complicated test. Fine.
Okay. Okay, next slide. So management overall, we need to monitor the platelet trend because majority the common cause of in thrombocytopenia majority will resolve spontaneously within a week, and if there is any bleeding tendency, we will give platelet transfusion or we will treat the underlying condition. Okay, next slide. So if whether we want to give platelet transfusion or not, there will be a guideline for platelet transfusion. So it is recommended platelet transfusion to maintain platelet count greater than 20,000 to 50,000 per microliter. So the guidelines like that. If a neonate has a platelet count that is less than 20,000 per microliter, the neonate should receive a platelet transfusion regardless of age and also the clinical condition. But in a neonate that have platelet count that is less than 30,000, indication to transfuse the platelet will include whether they have weight less than 1 kg, age less than 1 week, or any clinical instability, history of major bleeding, have current active bleeding, coagulopathy, or need for surgery or invasive procedure, then we will give the platelet transfusion. And also the third one is if neonates have platelet count that is less than 50,000 per microliter, then we will recommend to give platelet transfusion if there is significant bleeding only. Okay, that's all for neonatal thrombocytopenia. Any question?
Assalamualaikum. My name is Farah. I'd like to ask a question. So basically from your presentation just now, we can see that multiple diseases can cause thrombocytopenia, right?
Yes.
But this is the case of neonate. How about immune thrombocytopenic purpura? I mean ITP, right? So do we need to exclude all of these things, then only we come up with a conclusion of immune thrombocytopenic purpura, or can we just diagnose immune thrombocytopenic purpura by itself, ataupun kena exclude semua benda ni dulu kalau in case of neonate lah?
Okay. I'm not sure about ITP in neonates, but if the mother have ITP, then the baby can have autoimmune thrombocytopenia.
Who asked the question just now?
Me, doctor. My name is Farah. Sorry, I cannot tell you.
Okay, Farah, what is what is ITP?
It's immune thrombocytopenic purpura.
Yep. So what causes ITP?
So there's destruction of the platelet due to our immune system by itself.
Okay. So what triggers ITP? We don't know. Some people postulate that there is a viral infection, isn't it? And then what happens is our body produces auto antibodies that attacks our own platelet. So this is ITP. What did I say about autoimmune thrombocytopenia just now? So I did mention just now, isn't it?
Maternal antibody.
No, the issue is newborn babies, their immune system are not mature enough yet. Their immune system is not mature enough yet. So can they produce antibody? Yes, they can, but they don't produce antibodies well. So that is why usually even things like immunization. So some people questions why we give immunization early on, because the earlier you give immunization, the less antibody production, isn't it? So so that's the issue, because newborn babies, their immune system is not mature enough to mount an immunological response. So they don't produce adequate number of antibody. So if they don't produce antibodies, how can they have the typical ITP that we have in a bigger child or in adults? Faham? So they don't, sebab itu juga newborn babies, they don't usually have things like transfusion reaction. They don't usually have all this donor host punya reaction, because they don't mount adequate immunological response. Can they produce antibodies? Yes, they can. Can they mount immunological response? Yes, but it is not usually significant or strong enough. That is why they don't usually go into the usual ITP. But what can happen is, can they be affected by ITP? Yes, but not the antibody from themselves, but antibodies from mother.
Okay, faham. Thank you,
So,
Doctor.
another thing is antibodies from mother ni, you need to remember antibody ada macam-macam kan, ada IgA, ada IgG, ada IgM, ada IgE. So usually can IgG cross placenta?
Yes.
Yes.
So IgG is the one that usually crosses placenta. IgM don't usually cross placenta because IgM is a very big molecule. So, but certain IgM do cross placenta. For example, like dengue IgM. Dengue IgM is known to cross placenta. Most of the IgMs do not cross placenta. Can IgA cross placenta?
Usually through secretion.
IgA is through secretion. So from breast milk, for example. So, IgG can cross placenta. Itulah, but IgG is the one that has the memory, isn't it? Okay, all right, fine. Next, last one. Last one.
Yes. Okay, hello. Can you guys hear me clearly?
Yes.
Can.
Okay, Bismillahirrahmanirrahim. So we have come to the last part of the seminar. And this is just a short topic, but please pay attention because I might appoint anyone to answer my question at the end of this presentation. Okay. So the topic for my seminar today is hemorrhagic disease of newborn or HDN. However, that was the previous term used. So based on Nelson 21st edition, the newer term is vitamin K deficiency bleeding or VKDB. So I will use VKDB instead throughout this presentation. This is my outline for this presentation. Basically, it is divided into three, which is the introduction, the VKDB itself, and also how we approach the patient. So, as an introduction, neonates have a unique hemostatic system that places them at a high risk for hemorrhagic complication. At this age, the plasma levels, coagulation factors, thrombin, antithrombin, and also the platelet function are low or altered, as mentioned by doctor, because the mechanism in their body is not mature enough yet. So consequently, both congenital and acquired bleeding disorders can manifest in the newborn period. So the common acquired hemorrhagic disorder include this VKDB that I will talk about today. So hello, this is a very familiar figure of coagulation cascade. So I hope we still remember this. But today we will not go one by one or by each factor or step because we want to focus on the deficiency of vitamin K. So where is the role of vitamin K here? Okay, vitamin K is actually a cofactor for gamma carboxylation of coagulant factors 2, 7, 9, and 10. Okay. Vitamin K acts by converting these factors, these inactive clotting factors, into an active state to be used for the production of fibrin clot in our clotting mechanism during injury. So how do we remember the factors that are dependent to vitamin K? This is how I remember the mnemonic is 2 plus 7 is 9, not 10. So the vitamin K dependent clotting factors are factor 2, 7, 9, and 10. Vitamin K is a fat-soluble vitamin mainly synthesized by the gut bacteria and then stored in the liver and adipose tissue. So these are the three types of vitamin K. The bacteria in the GI tract naturally make vitamin K, known as menaquinone or vitamin K2. Vitamin K1 or phytoquinone are the dietary sources of vitamin K, which include green leafy vegetables such as spinach, broccoli, cauliflower or cabbage, and also the vegetable oils and dairy products. And the third type is the menadione, which is a vitamin K3, or the synthetic type of vitamin K. Okay, this is just an extra information to show you guys that there are higher level of vitamin K or specifically vitamin K1 in the formula fed as compared to the breastfed infants. Okay, this is an important point for you guys to you will later understand that why hemorrhagic complications are more frequent in exclusively breastfed than in mixed breastfed or formula fed infants, simply because the breast milk is a poor source of vitamin K. Okay, now let's go deeper about the VKDB itself. So I am sure that you guys have grasped the gist of VKDB. And now, for the sake of knowing the definition, based on Nelson 31st edition, it is an acquired coagulopathy secondary to transient but severe deficiencies in the vitamin K dependent factors and is characterized by hemorrhage. Very simple definition. So what is the pathophysiology? Newborn infants are at risk for vitamin K deficiency because their immature liver does not efficiently utilize vitamin K from the gut. And another point that you should add from this slide. Okay, this slide is the one that I have made correction. Okay, please pay attention to this slide. Okay. Another point is they have a low vitamin K stores because there is sterile gut. In neonates, there is absence of or lack of gut bacteria that produce or synthesize the vitamin K. And also there is poor placental transfer of vitamin K or low vitamin K content in the breast milk. It should gradually increase and reach the normal limits within a month after birth. However, if there is severe deficiency, it will lead to inadequate activity of the clotting factors, which will then result in spontaneous and prolonged bleeding, which is the hemorrhagic disease of newborn or vitamin K deficiency bleeding. Okay, the bleeding can occur in GI tract, from the intracranial and also in the joints, and you can also see bruises, petechiae purpura. It also causes alteration in the intrinsic and extrinsic coagulation pathway, which causes the prolonged PT, APPT, and INR. So, VKDB is classified according to the onset of the hemorrhagic episode. So, if it occurs within the 24 hours of life, it is the early onset. And next, the classic onset is the most common, which happen during the 2 days of life until 7th day of life. 2nd day of life to 7th day of life. And then the late onset is between 2 weeks to 6 months of age. Okay. For early onset VKDB, it can happen if the mother has been treated chronically with certain drugs, such as, of course, the anticoagulant, warfarin, anticonvulsant, phenytoin or phenobarbital, or even the cholesterol-lowering medication that will interfere with the vitamin K absorption or function. However, early VKDB is very rare. So for classic VKDB, it is common and most often in exclusively breastfed infants who did not receive any vitamin K prophylaxis at birth. Because, as I mentioned, the breast milk is a poor source of vitamin K. So, severe vitamin K deficiency is also more common in premature infants because lack of free vitamin K from the mother, coupled with absence of bacterial intestinal flora, normally responsible for the synthesis of vitamin K. And then the third one is the late onset VKDB. It associated with conditions that feature malabsorption of the fat-soluble vitamin K, such as the cystic fibrosis, neonatal hepatitis, and biliary atresia. So, the bleeding in VKDB can be at anywhere, but most frequently, bleeding tendencies occur in the GI, nasal, subgaleal, intracranial, or during the post-circumcision circumcision. Okay, this figure shows examples from true cases of BKDB where you can see.
We are back. Okay, so we are talking about neonatal thrombocytopenia, is it? Basically neonatal hemorrhagic disease of newborn. Why are we talking about circumcision, post-circumcision?
Because some people prefer to do the circumcision at early age.
Okay, yes. The issue is even if you look at hadith, there are many sources saying that circumcision for male is done at day 7 of life. Even female circumcision, if it's done early. Is done as early as possible. So only in countries like Malaysia. How old do we circumcise children, male children?
7 to 12.
Usually more than 9 years old, 9, 12 years old. But if you even if you look at AAP, American Association of Pediatrics, the suggestion for circumcision, this is not religious for religious purposes. So circumcision is beneficial if it's done early, less than 6 months old, because before 6 months old, UTI is more common in male rather than female. After that, it's more common in female. So that is why doing circumcision early is actually beneficial. There's hadith mentioning that circumcision in male is done by day 7 of life. But the thing is, in Malaysia, it's not common. It's not common yet. If you wanna circumcise babies in Malaysia, it needs to be done by surgeon. But in many countries, if you go to UK, for example, for Muslim, so it's not just Muslim that circumcise. Christians also circumcise. Jews also circumcise. If you look at Christians living in Philippines, for example, majority of Philippine Christians, they are circumcised. So in many of these countries, circumcision are done early. Even in UK, it's done very early by day 7 of life, before 3 months of life usually, circumcision is done. So that is why we can see the classic onset disease where bleeding occurs around day 2 to day 7 of life, because circumcision is done early. Why I mention this is because one of the questions for the final professional exam that I just marked yesterday, PMP questions, we were talking about UTI, about a child with hydronephrosis and hydroureter. So among the questions asked is the Islamic component. So we asked about what is the advice. So the advice should be circumcision. But then your seniors answered. I felt depressed reading the answers. And some say, okay, fine. The thing is, we all in Malaysia, we should be Shafi'i, isn't it? So what is the ruling for circumcision, male circumcision for Shafi'i? Is it advisable? Is it ibahah, harus, or is it sunnah, or is it sunnah muakkadah, or is it wajib? What is it? What is the ruling for male circumcision? Under Shafi'i, it is wajib. It is compulsory. It is compulsory for male to be circumcised before baligh. Kan? But the thing is, your seniors answer with so many fatwas lah, macam-macam. Sunat muakkad, macam-macam. Advisable. What advisable? What when you talk about Islamic? What do you mean by advisable? Kan? So I felt depressed reading it, and then some of your seniors mentioned Islam does not advise circumcising early. What is this? Kan? The best I can do is give 0 mark, but then I don't know how we're going to correct this before they all become doctors. So okay lah, fine. It's alright. Proceed.
So next, so this figure shows examples from true cases. The first one is the extensive skin hemorrhage. that is complicated with sepsis. Okay. And B is the abdominal organs from severe umbilical hemorrhage. As you can see, the liver is hard and the gallbladder and bile duct are hypoplastic. C is the microscopic view of the subcutaneous hemorrhage, and this is the subarachnoid and the subcapsular liver hemorrhage. So, how do we approach the bleeding newborns? So for history, as I mentioned, you have to ask all the risk factors like the maternal medication use during pregnancy, and also for fetal, you have to ask about the vitamin K prophylaxis, and also if there any use of antibiotics, or if the baby has diarrhea, or the feed is exclusive breastfeeding. Okay. On physical examination, you should not miss any bruises or bleeding, and it can occur anywhere through the mucosal surfaces, GIT, umbilicus, or circumcision site. Uh, okay, it can bleed anywhere from anywhere. You should note that the prodromal or warning signs, which is the mild bleeding, may occur or may present before the serious intracranial hemorrhage. Okay, the lab testing reveals that the PT, APTT, and INR in VKDB is prolonged. However, the platelets and fibrinogen are normal because this is not the thrombocytopenic disorder. Okay? Other than that, the plasma levels of factor 2, 7, 9, and 10 are substantially decreased. And the main thing here is the PIVKA. Okay, anyone knows what is PIVKA? Afika knows what is PIVKA? Okay, PIVKA is protein induced in vitamin K absence. Okay, so PIVKA will be excess in VKDB. This is the most sensitive marker, and its estimation is very helpful in diagnosis even after starting the treatment. So for other investigation, if you notice any neurologic symptoms, you should find the evidence of brain hemorrhage using radiological imaging, which is the CT and MRI. And also do the full blood count to exclude other causes of bleeding, such as the thrombocytopenic disorders. And also, another thing that is important in NCC, what is the another thing that is important?
Presenter, neuroimaging, can you do cranial ultrasound rather than MRI?
Not sure.
Or can you do CT scan rather than MRI?
CT can, but ultrasound I'm not sure.
Okay, the answer to all is can lah actually. Can is never the question. Usually if I ask can, the answer will always be can lah most of the time.
Okay.
Good question. Okay, fine. So the thing with cranial ultrasound is very good to see things like intraventricular hemorrhage, but it is not as great to look at parenchymal hemorrhage, and it's even worse to look at things like subarachnoid or subdural hemorrhages as well, especially for posterior bleedings and so on and so forth, because usually we do cranial ultrasound through the anterior fontanelle. You can do from posterior fontanelle as well. You can do from the sagittals, but then it's difficult. Many people are not trained. It's very difficult to see. So usually cranial ultrasound you can do, but it's quite difficult to see. CT scan also you can do. You can see bleeding, but obviously MRI has the best images for you to see in terms of bleeding and in terms of the tissue destruction and so on and so forth. But the problem with MRI is it's very difficult to get early. It's very difficult to get early. CT scan you can, because CT scan is just less than half an hour. MRI is going to take longer. Usually it's very limited number of patients that we can do MRI. Okay, all right, fine.
Okay, example. What is the most important component that you have to look for in the full blood count? Al-Ami? Tak ada dah. So the most important thing is the hemoglobin because you have blood loss, right, in VKDB. So there will be anemia. Okay, to manage VKDB, it can be divided into prevention and treatment. So for prevention, first and foremost, the important thing is to avoid the high-risk medication in mother and also in the fetus. And also, we have to encourage everyone to get vitamin K prophylaxis at birth. And MOH guideline recommends the intramuscular administration of IM vitamin K. Okay. If the baby has already presented with hemorrhage, you can give a slow IV infusion of 1 to 5 milligram of vitamin K1, and it is an effective treatment. Then can lead to improvement in coagulation defects and cessation of the bleeding within only a few hours. Okay. If there is severe bleeding, particularly in premature infants or those with liver disease, you may consider transfusion of fresh frozen plasma or even the whole blood if needed. So why do we give fresh frozen plasma? Can anyone answer? I will give a prize. Jamila?
Because it contains all the
Okay.
coagulation factors.
What?
Because it contains all the coagulation factors.
Okay, true. And another thing in the FFP, other than the 2, 7, 9, 10, tahu tak? Okay, dia ada protein C and also the protein S. And then the last one, you have to treat the underlying cause. Okay, thank you, Badro. Saya dapat hadiah separuh. And then neonates that come with bleeding, you should also think of other differentials such as the IVC, neonatal thrombocytopenia as mentioned, hepatobiliary disease, and also hereditary bleeding disorder. So that's all from me. Any questions?
How about hemophilia?
Oh, hemophilia. Yes, hemophilia is the congenital cause of hemorrhagic disorders in neonates.
So we need to think of hemophilia as well. I have seen personally one of my patients. So the moment we each time we put cannula in, bruise. Each time we put any venipuncture, it becomes bruising. Initially, the APTT wasn't that deranged, and then subsequently we have very deranged APTT. So don't forget about hemophilia. Von Willebrand disease is yes, but it's much rarer. It's much rarer, von Willebrand disease.
That's all from me.
All right, good. Any question?
My name is Farah. I would like to ask a question. So I have 2 questions actually. So my first question is siapa yang kita patut bagi vitamin K prophylaxis, all babies or certain high risk babies? Number 2 is that does maternal prophylaxis IM vitamin K helps kalau kita bagi prior to birth?
Okay, from my reading. So vitamin K prophylaxis given at birth, vitamin K prophylaxis to the baby given at birth is mandatory actually for all babies. However, due to the rising cases of like anti-vax dan semua ni, so adalah cases yang orang akan tolak ada prophylaxis. Okay, and then for mother, prophylaxis for mother during pregnancy dulu ada, but now studies showed that there are not significant effect for prevention of VKDB, so it's not recommended anymore.
Okay, let me correct the answer. Okay. So it is not mandatory.
Encouraged.
There's not many things in Malaysia that is mandatory lah. But the guideline is we give vitamin K prophylaxis to all babies. Except for extremely ill babies, extreme premature babies. Sometimes we delay a bit, but even then, usually we prefer to give as soon as possible. So So sometimes kita tak bagi, we delay just because at that particular time the patient is still unstable. The moment we transfer the baby over to NICU, we'll give there. So it's not like we delay for a very long time. Because usually vitamin K prophylaxis is given in the labor ward, in theatre or in labor ward. So at birth, the moment baby is born, we give vitamin K. So the reason why, because we don't want to miss, because we don't want the patient to bleed first. So that's the reason. And we give to every babies. And we give the one that we give is K1, which is phytomenadione. There are several preparation for vitamin K, and some of them has problem with GSPD deficiency as well. It can cause hemolysis in GSPD deficiency babies. So basically, yes, I acknowledge what the presenter have said. The issues now is that we are having more anti-vaxxers community. One of them successfully sued one of our doctor colleague recently. So anyway, the issue is they don't understand what is vitamin K. Vitamin K is vitamin. So because I've seen many of the birth plans, sometimes they say I don't want, I refuse my baby to receive any type of vaccine. So fine, if they are anti-vax, then we understand. But vitamin K is not vaccine, so it's very different thing. But people don't understand. So I think we need to acknowledge, we need to understand, but there's no role of us fighting with them. I think there's no, many of these anti-vaccine, they have fixed false belief. So whatever the, you cannot convince them otherwise. Whatever you try, how much evidence that you show to them, most of the time they won't change. They have fixed false belief. So I think what we can do is just convince the people that can still be convinced. And then the thing is with maternal vitamin K, the issue is the amount that crosses the placenta is not significant enough for it to show any change for the baby lah. Okay, all right. Any other question?
Thank you, Dr. and presenter.
Manisa, I have a question. Regarding, you mentioned one of the classic cause is exclusive breastfeeding, right, compared to giving formula milk. So if the patient have vitamin K deficiency, would you recommend the mother to stop breastfeeding and proceed with formula milk, or would you actually encourage? Because in normal practice, we actually encourage mothers to exclusive breastfeed for at least 2 years. So how would you approach that?
Good question. Actually, I'm not sure about that. But okay, tak nak lah, tak tahu doktor.
Okay, before I answer, I want to correct the question itself. There's a very gross problem with the question. The questioner, Amin nama. So Amin says it is advisable for exclusive breastfeeding for how long?
For a second, about 2 years, right, Doctor?
Okay, that's totally wrong. Because exclusive breastfeeding means you only breastfeeding without no other sort of formula, no sort of other feeding. It's just breastfeeding. So exclusive breastfeeding is only up to 6 months. Maximum is 6 months. Exclusive breastfeeding is only up to 6 months. So beyond 6 months, breastfeeding alone is never enough. So beyond 6 months, you need some other weaning with either with other milk, with soft diet, with so on and so forth. So after 6 months, you should wean the child. You can even start weaning by the age of 4 months old. So weaning starts 4 to 6 months. So exclusive breastfeeding is below 6 months. That doesn't mean you do not breastfeed after 6 months. So you should continue breastfeeding until 2 years. There's so many hadith, there's so many, there's Quranic verses mentioning about breastfeeding up to 2 years old. And there's a verse in the Quran saying you breastfeed for 2 years if you want, and so on and so forth. There's so many benefits of breastfeeding up to 2 years old. But That does not mean it is exclusive breastfeeding. So breastfeeding 2 years old, but from 6 months onward, you need to wean with other semi-solid food lah. Okay, all right. So exclusive breastfeeding has lower content of vitamin K. Does it mean we do not breastfeed? No. It's the same like breastfeeding jaundice. It's the same as breast milk jaundice. So now you know breastfeeding, breast milk, all can cause jaundice as well. Does it mean we need to stop breastfeeding? Does it mean we need to stop breast milk? No. We continue, we give more. So the only issue about this is that we need to acknowledge babies that are solely breastfed, they usually have lower number of vitamin K. So if they have bleeding, you need to consider giving extra vitamin K by IV, IM, so on and so forth. So we acknowledge as well babies that are formula fed, usually they have higher level of vitamin K. But that never means that formula fed babies are better. No, because they only have extra in terms of vitamin K and some other issues. But breastfeeding, we acknowledge, yes, they have lower vitamin K. Breastfeeding has lower level of calorie, for example. So breast milk only has 67 kilocalorie per 100 meals. If you look at formula milk have 69 to 71 kilocalorie per 100 meals. That doesn't mean formula feeding is better, because breast milk breastfeeding has so many other benefits. Babies who are breastfed, studies have shown they have higher IQs later in adulthood. Babies who are breastfed, because breastfeeding affects the satiety center. So they have breastfeeding reduces the risk for childhood obesity. Breastfeeding reduces the risk for adult obesity. Breastfeeding reduces the risk for congenital cardiovascular diseases in adulthood. Breastfed babies are associated with better EQ at later ages. Breastfed babies has lower risk for suicide, for example. So babies who are breastfed has better mental punya issues. Their mental stability is much better. Breastfed babies they have issues with the microRNA. So they have better immune system because breast milk have IgA, has higher WBC count, and it is specific to the age. Premature babies has different breast milk as compared to term babies. Male babies has different breast milk as compared to female babies. So breast milk is specific to that particular child's need. So whatever the thing is, breastfeeding is still better. So there's we do not stop, but what we do is we encourage to give more. But we, at the back of our mind, we need to remember breastfed babies, they have lower level of vitamin K. All right, clear?
Thank you, Doctor.
Fahim Tum Kalami?
Faham.
Fahim nah jawabnya. Okay. All right. Any other question?
Actually, Doctor, ada one more question actually. Regarding rhesus disease, say you mentioned if the mother having rhesus disease at the first pregnancy, and then we didn't give, she denied or we didn't give any program prophylaxis. With the second pregnancy, if the second pregnancy is also rhesus positive, would the baby able to survive?
Who presented this topic? Anemia.
Anemia.
Siapa yang anemia? Please answer.
Assalamualaikum. From what I've read, actually, in rhesus immunoincompatibility, there's actually, if we didn't give rogam in with subsequent pregnancies, the severity that can be caused to the fetal is actually more severe in the subsequent pregnancies rather than the ABO incompatibility. It's from I've read. I'm not sure.
Well, that's true lah. So if the question is whether the baby can survive, yes, the baby can survive. But the risk and the problems will be more. The risk and the problems will be more. That's it.
Thank you, Doctor.
Okay. All right. Any last question? Sekolah. Sorry, almost 1.5 hours. Okay lah. I think if there's no question, I would like to thank all the presenters. I think the presentation has been quite okay lah. Well, obviously, this sort of online teaching is never as good as the usual face-to-face teachings. At least if face-to-face teaching, I can see who's actually sleeping. And macam ni sekarang ni, you all ada tak ada, kamu tak tahu kan. Hidup lagi ke tak pun tak sure. So, okay, fine. Let's end our session with tasbih kafarah surah Asr. Okay, Assalamualaikum.
Jumpa esok, Doktor.
Waalaikumsalam.
Thank
Thank you,
you,
Doktor.
Doktor.